Good morning. My name is David Adler and I am a physician in Sandton MediClinic. Today's Nexus 101 series will discuss the management of venous thromboembolism in 2017. It is really imperative that an early and accurate diagnosis of venous thromboembolism is made. Potentially life-threatening events may occur if a thrombotic episode is missed or unnecessarily anticoagulation is given. There's also the financial cost and the radiation exposure of CT pulmonary angiography. Today's discussion will only concern on primary VTE. We will not discuss recurrent VTE, cancer-related VTE, pregnancy-related VTE, or superficial vein thrombosis. In the management of venous thromboembolism, we need to discuss both diagnosis and treatment. From a diagnostic point of view, we look at three areas. The first is the clinical decision rule. In other words, do we suspect a venous thromboembolism? If this is positive, we then move on to biomarkers, and for a deep vein thrombosis we use the D-dimer, and for the pulmonary embolus the D-dimer, and proBNP and troponin T are used for prognostic significance. If these are positive, we then move on to a confirmatory radiological diagnosis. For deep vein thrombosis, that's compression, ultrasound and Doppler. We can use a CT or more recently MRI. To diagnose a pulmonary embolus, we use a CT pulmonary angiogram or VQ scan, and echocardiography is used from a prognostic point of view. To begin, we will look at the clinical decision rule for deep vein thrombosis. There are a variety of different scoring systems. This is the Wells probability score, where different clinical features are attributed to different points. Active cancer, paralysis, paresis, recent immobilization, local tenderness along the deep venous system, leg swelling, calf swelling of greater than 3 centimeters larger than the asymptomatic side, unilateral pitting edema, collateral superficial veins, or a previously documented deep vein thrombosis all score 1 point. If there's an alternative diagnosed as likely or more likely than deep vein thrombosis, in other words recent trauma, scores -2 points. This score is tallied, and if it's less than 2, the deep vein thrombosis is unlikely. If it's greater than 2, the deep vein thrombosis is likely, and then we move on to the second point of biomarkers. The main biomarker we use for venous thromboembolism is the D-dimer. D-dimers come from degradation products from cleavage of cross-linked fibrin. This is the diagram of the degradation product. In the center here, we can see the cross-linked fibrin. It's broken down into plasmin into these degradation products of D-dimers. The normal values of D-dimers are less than 500 nanogram per mol, but we do find higher normal values with age and pregnancy, and unfortunately numerous false positives with any inflammatory condition, and therefore we only do a D-dimer if there is a suspicion of venous thromboembolism. The algorithm for deep vein thrombi: we start with the clinical decision rule, and if it's either a low or a moderate probability, we start with the D-dimer. If the D-dimer is less than 500, no further testing is required, and if it's greater than 500, they then need a compression ultrasound. If there is a high clinical probability on the clinical decision rule, there's poor sensitivity with the D-dimer, and we move straight ahead onto the compression ultrasound. The gold standard for diagnosing deep vein thrombosis is the compression ultrasound with Doppler, which is non-invasive and safe and relatively inexpensive. Unfortunately, there are technical issues with calves and obesity, and there is poor sensitivity in calf and pelvic veins. For the calf vein thrombi, we may require serial ultrasounds to confirm the diagnosis, and the pelvic vein thrombi, some other modality, for instance a CT, or new work is being done for MRI. For the clinical decision rule for pulmonary emboli, again there are a number of different scoring systems, and this is the modified Wells criteria. Clinical symptoms of deep vein thrombosis score 3 points, and if another diagnosis is less likely, scores -3 points. Tachycardias, recent immobilization or surgery, and previous deep vein thrombosis or pulmonary emboli score 1.5 points, and hemoptysis and malignancy 1 point. The scores are tallied, and depending on the scoring systems, whether it's a low, moderate, or high clinical probability. The biomarkers: the D-dimer is as with the deep vein thrombosis, and the proBNP, which comes from a polypeptide released by ventricles in response to stretch, and it's really a measure of right ventricular strain, and is not diagnostic of pulmonary emboli, but rather prognostic. Likewise, the troponin T is a muscle protein released by injured myocardium, and again a measure of right ventricular strain, and not diagnostic, but really prognostic. The algorithm for pulmonary emboli. With the algorithm for pulmonary emboli, if the clinical decision rule shows a low probability, to try and avoid a CT angiography, which you mentioned earlier has got both cost and radiation issues, we do the PERC rule. The pulmonary embolism rule-out criteria, or PERC rule, are looking at these low-risk people and trying to avoid any unnecessarily CT angiography. There's 8 criteria, and if all 8 criteria, which include age less than 50, or heart rate less than 100, SATs of greater than 95%, no hemoptysis, no estrogen use, no previous VTE, no unilateral leg swelling, and no recent immobilization. If all are positive, no further testing is required. If any of the PERC rule criteria are negative, we then move on to the D-dimer, and again less than 500, no further testing is required, greater than 500, either the CT pulmonary angiography or a VQ scan. A moderate probability goes straight to the D-dimer ruling, and as with the high probability of a deep vein thrombosis, the D-dimer is not necessarily, and we go straight onto the radiological procedure of either the CT pulmonary angiography or a VQ scan. The gold standard for diagnosis of pulmonary embolus is a CT pulmonary angiogram. The beauty about the CT is that it reveals other conditions that may mimic pulmonary emboli, for instance pneumonia and cancer. The 2 big drawbacks are iodine allergy and renal dysfunction, and what people often do to overcome these problems is that we start treatment while we prep him with cortisone for iodine allergy and prehydrate for the renal dysfunctions. The CT angiogram is also poor with subsegmental pulmonary emboli. Here is a CT pulmonary angiogram, and this reveals these 2 large filling defects in the proximal pulmonary arteries. The alternate scan to the CT pulmonary angiogram is a VQ scan, and unlike the CT, is safe with iodine allergy and not concerned with renal function. Unfortunately, the VQ is not nearly as accurate as the CT and does not show other pathology. This is a VQ scan with the ventilation scan on the left and the perfusion scan on the right, and you can see these mismatched perfusion defects in both lung fields. The second part of the talk is about treatment. This slide is an overview of the management of venous thromboembolism. Not all patients with VTE need to be anticoagulated. Those patients that need anticoagulation must be weighed as regards to bleeding versus thrombotic risk, and once that's done, who needs to be treated as an outpatient, who needs to be admitted, and who needs urgent referral. So to start with, do we need to anticoagulate all patients with venous thromboembolism? The 2 groups of patients that might not require anticoagulation with venous thromboembolism are the patient with the small distal provoked deep vein thrombi or the isolated subsegmental pulmonary emboli that are found in CAT scan for other indication, for instance staging cancers. The second group of patients where the bleeding risk outweighs the clotting risk. So to start with, the distal provoked asymptomatic deep vein thrombi, if a patient presents with minor symptoms, the small muscular vein deep vein thrombosis, if it's provoked, if it's transient, reversible risk factors, a low D-dimer of less than 500, and no previous venous thromboembolism, it is reasonable to do serial weekly ultrasounds and to observe them. With the small submental pulmonary emboli, if there's no deep vein thrombosis and there's a low risk of recurrent venous thromboembolism, these patients can also be watched for serial assessments. If there's an active or high risk of bleeding and anticoagulation cannot be given, the patient needs to have an inferior vena cava inserted, and as soon as the bleeding risk is resolved, to begin anticoagulation. To assess the bleeding risk, we look at different factors: age, over 65 years old, previous bleeding issues, active cancer, organ failure with either kidney or liver, thrombocytopenia with platelets less than 50,000, uncontrolled diabetes, and previous strokes. On a medication list, antiplatelet agents including aspirin, clopidogrel, anti-inflammatories, and a variety of homeopathic drugs, poor anticoagulant control on warfarin, recent surgery, frequent falls, and alcohol abuse. We can stratify the risk of bleeding based on the number of risk factors. A low risk, that's no risk factors present, there's a risk of 1.6% of bleeding the first 3 months and 0.8% after that. The intermediate risk, that's one risk factor present, the 3.2% in the first 3 months and then 1.3% following that. And then the high risk, that's 2 or more risk factors, a highly significant 12.8% bleeding risk in the first 3 months and more than 6.5% following that. So how do we actually treat venous thromboembolism? The important areas are, do we manage patients at home or as an inpatient, and who requires urgent referrals? What drugs we use, and that depends on the initial, long-term or indefinite anticoagulation. And then the duration of the anticoagulation depends on the site of the thrombosis, whether it was provoked or unprovoked, and whether there's transient or permanent risk factors present. To begin with, who needs urgent referral? Any patient with a suspected pulmonary embolus with hemodynamic compromise, including right ventricular strain with a positive troponin T or pro-BNP, needs urgent referral, and likewise a patient with a suspected proximal vein thrombosis with phlegmasia ceruleus dolens. And there's a picture over here with the left leg with an extensive deep vein thrombosis. Whether the patients are managed at home or as inpatient depends on a variety of factors. There's a thrombotic factor, which is the extent of the thrombosis, clinical factors including comorbid conditions and clinical stability, and finally logistical factors, what the home circumstances are like and what to do with any follow-up or if there are any complications. So generally speaking, if it's a small thrombosis, there's no other clinical conditions, the patient is stable, good home circumstances, they can be managed as an outpatient. Moving on to the anticoagulants, we divide the anticoagulation into 3 periods. The first is the initial anticoagulation, that's the first 10 days. Long-term anticoagulation is from 10 days to 3 months, and indefinite anticoagulation is greater than 3 months. With the initial anticoagulation, that's the first 10 days, we have 4 options. We can use a low molecular weight heparin, either daily or twice daily, fondaparinux, or the 10A inhibitors. Intravenous unfractionated heparin is an option, but that's really reserved for in-hospital use for patients that may require surgery with urgent reversal. We can't use the 2A inhibitors, and aspirin is not indicated in this situation. With the initial trials, the 10A inhibitors were used initially, whereas the thrombin inhibitors had a lead-in phase with the low molecular weight heparins or the fondaparinux. The dosage for the 2 available low molecular weight heparins in the country, enoxaparin and nadraparin, Clexane is 1 mg per kilogram twice daily or 1.5 mg daily. The fraxiprin is either 86 anti-factor 10A units twice daily or 171 anti-factor 10A units daily. For fondaparinux or Rixtra, it's weight-based. If it's less than 50 kilograms, it's 5 milligrams subcut. Between 50 and 100 kilograms is 7.5 milligrams subcut, and greater than 100 kilograms is 10 milligrams subcut daily. The unfractionated heparin is a starting dose of 18 units per kilogram per hour of infusion, and that's adjusted as per the APTT. The new 10A inhibitors, that's Xarelto from Bayer Pharmaceuticals, is 15 milligrams twice a day orally. With long-term anticoagulation, that's 10 days to 3 months, we have 4 options. We can continue with the 10A inhibitors. The 2A inhibitors can be started, although there needs initial lead-in with the heparins. The vitamin K antagonists, like warfarins, can also be used in this indication, but again need a lead-in with the heparins. Low molecular weight heparins, unfractionated heparins, and pentasaccharides can be used in this indication, but they're generally reserved for patients with cancer-associated thrombosis, pregnancy, or with patients that may require urgent reversal. Aspirin, again, is contraindicated in this indication. The novel anticoagulants, that's the 10A inhibitors and the 2A inhibitors, are preferred to the vitamin K antagonists due to their far better safety profile. The dosage for the 10A inhibitors is to continue with the 15 milligrams twice daily for 3 weeks, following on with 20 milligrams daily orally. We can dose adjust to 50 milligrams daily for a high bleeding risk patient or patients that are on antiplatelet therapy. With the 2A inhibitors for Pradaxa, the dose is 150 milligrams twice daily, and the trials show there's no dosage adjustment necessary for either patients at bleeding risk or antiplatelet therapy. The vitamin K antagonist, the warfarin that's well known, we base it according to the INR, together with all these drug and food interactions. Finally, we look at the indefinite anticoagulation that's greater than 3 months. With indefinite anticoagulation that's greater than 3 months, the novel anticoagulants of the 10A inhibitors and the 2A inhibitors are preferred due to their better safety profile over the vitamin K antagonists. The heparins are normally used for patients with cancer-associated thrombosis, pregnancy thrombosis, or patients that might require surgery, and again, there's no role for aspirin. The dosage is the same as the long-term anticoagulation. With the 10A inhibitors, it's 20 milligrams daily, or 15 milligrams for the high bleeding risk, or patients that are on antiplatelet therapy. Recent work has just come out that in a patient that may require longer-term anticoagulation, we can use 10 milligrams daily. The 2A inhibitors, that's a stable 150 milligrams twice daily orally, or the vitamin K antagonists as per the INR. The duration of anticoagulation depends on whether the venous thromboembolism was unprovoked or it was provoked with either a transient risk factor or a permanent risk factor. So following the first episode of VTE, all patients receive a minimum of 3 months of anticoagulation and then they're reassessed. They're reassessed on the thrombotic versus bleeding risk, whether the VTE is provoked or unprovoked, whether there's a transient versus a permanent risk factor, and patient preference also plays a role. So on this algorithm, we start with the first venous thromboembolism and then receive 3 months of anticoagulation. If the risk is provoked and it's a transient risk factor that's resolved, we stop the anticoagulation after 3 months. We do warn patients about possible recurrence and that there are certain episodes where we need VTE prophylaxis, for instance surgery. On the other side of the equation is a patient with an unprovoked venous thromboembolism, and unless it's contraindication, they require long-term anticoagulation. The difficulty is this middle group of patients. So these are patients with a provoked venous thromboembolism and either a transient risk factor like cancer that's unresolved or a permanent risk factor like thrombophilia. These patients need to be assessed for the risk of bleeding versus thrombotic risk. There are a variety of prediction models. This one is called the DASH prediction score. We score it with an abnormal D-dimer after stopping anticoagulation scores 2 points. People under the age of 50 score 1 point. Males score 1 point. And if the patient was taking hormones at the time of VTE onset, they lose 2 points. The scores are added, and if the DASH score is less than 1, the annual VTE recurrence rate is 3.1. A score of 2 gives 6.4% annual VTE recurrence rate, and a score of greater than 3, 12.3%. So by comparing the risk of recurrence versus the bleeding risk, if for instance we take a patient with a low risk of bleeding, that's less than 1 risk factor of 1.6, and we take a high risk of recurrence, say 12.3%, we'd continue the anticoagulation. Going the opposite way, where it's a low risk of recurrence, say 3.1%, but a high rate of bleeding, you'd stop the anticoagulation. There will be a group of patients with clinical equipoise. With this group of patients, we can discuss patient preference to either continue or stop anticoagulation. And there is new work come out on the Einstein Choice trial that looked at this group of patients and found that 10 milligrams of rivaroxaban was as safe and effective as a rivaroxaban 20 milligrams daily. There are additional therapies to consider. Graduated compression stockings are not for routine use. Thrombolysis, this is obviously done in a hospital, and it's used with patients with extensive iliofemoral vein thrombosis, like the picture we saw earlier of the phlegmasis cerulea dolens, or patients with pulmonary emboli with hemodynamic compromise. And the thrombolysis can be either given intravenous or catheter directed. Filters, this is used for patients with an absolute contraindication to anticoagulation, to patients with recurring pulmonary emboli despite adequate anticoagulation, or patients with a deep vein thrombi with poor cardiac reserve who cannot afford a further pulmonary embolus. We need to anticoagulate as soon as it's safe and to remove the filter as soon as possible. Thank you for your attention. If you have any comments as regards the presentation or Nexus Academy, please contact us through the available contact details. Thank you.